Unmute yourself.
Yes, sir.
Go ahead, please go ahead.
Thank you. Please proceed, Doctor.
My topic of presentation is intraoperative pulmonary edema. Starting with definition, pulmonary edema is defined as accumulation of a fluid in the lungs due to extravasation from the pulmonary vasculature into the interstitium and alveoli. Types of pulmonary edema, there are mainly two types of pulmonary edema: cardiogenic pulmonary edema, non-cardiogenic pulmonary edema. Coming to etiology, cardiogenic pulmonary edema, the causes can be left ventricular failure, dysrhythmias, left ventricular hypertrophy, cardiomyopathies, left ventricular volume overload, myocardial infarction, LVOT obstruction, uncontrolled hypertension, to name a few. Causes of non-cardiogenic pulmonary edema are neurogenic pulmonary edema, high altitude pulmonary edema, post aspiration pulmonary edema, re-expansion pulmonary edema, post thoracocentesis, post extubation pulmonary edema, or the negative pressure pulmonary edema, and others like inhaled toxins, lymphatic obstruction, post lung transplantation, etc. Stages of pulmonary edema, three stages to name. First stage is there is excess of fluids in the lung, which are basically cleared by the lymphatics. Stage 2 is interstitial edema, and stage 3 is alveolar edema. Our concern when the patient is under anesthesia is basically with the negative pressure pulmonary edema or the post-obstruction pulmonary edema. Incidence of this being 0.05% to 0.1% in all anesthetic practices, and morbidity, while morbidity and mortality for this is as high as 40%. Predisposing or risk factors for this is this could be difficult intubation, short neck, ET tube obstruction with secretions, history of OSA, obesity, acromegaly, upper aerodigestive tract surgeries in children, young athletes, male sex, usually vocal cord paralysis, and greater incidences in ENT surgeries. The negative pressure pulmonary edema are again categorized into two types: the type 1 and type 2. Type 1 being due to sudden intense obstruction, which could be during post extubation, laryngospasm, or epiglottitis. And type 2 is after the surgical release of chronic airway obstruction, like resection of laryngeal tumors or adenoids or tonsils, intrathoracic goiters, and sudden release of PEEP or from positive pressure ventilation. Coming to pathophysiology, pulmonary edema is basically the phenomenon of alveolar capillary membrane injury after exposure to subatmospheric pressure. Two forces govern this phenomenon. First is the Laplace law, which takes place inside the pulmonary capillaries. That is, increase in the transthoracic pressure increases the transmural pressure, and that is increased circumferential stress on the blood gas barrier and the pulmonary capillaries, which leads to failure of the blood gas barrier, and then there is extravasation of fluid and blood, leading to alveolar edema. And coming, the second is the Starling's forces, which is inside the alveoli and the interstitium, that is high negative intrathoracic pressure, will lead to increase alveolar or the transpleural pressure, which will further lead to increase in the venous return to the right side of the heart, increasing the pulmonary artery or the pulmonary capillary wedge pressure, hence increasing the interstitial hydrostatic pressure. So there is transudation of fluid, causing transudative pulmonary edema. The normal oncotic pressure is 25 mm of Hg, and the normal osmotic or the hydrostatic pressure is 15 mm of Hg. So basically, when there is a difference between these two pressures, there is extravasation of fluid into the alveoli. Theories, the two main theories governing NPPE is the hydrostatic fluid shift first, and the second is the mechanical stress. Mechanical stress, as in when there is a when patient under anesthesia is undergoing positive pressure ventilation or with PEEP, there is expansion, there is increase in the end expiratory lung volume. There is some amount of volume trauma as well, so relief of PEEP would return the lung volume, causing pulmonary capillary damage, or there is increase in the pulmonary capillary wedge pressure, hence causing a pulmonary edema. Clinical signs and symptoms: patient under anesthesia, there would be sudden onset of tachycardia, tachypnea. There can be confusion, hesitation, anxious, diaphoresis, hypertension or hypotension, cool extremities. There can be creps, rales or wheeze, accentuation of S2, heart sound, IJV, distension. The, S3 can be present, pink frothy sputum, which is the hallmark of pulmonary edema. There can be desaturation or hypoxemia on ABG, and chest X-ray shows curly hair, B lines or bat wing appearance. Complications, if untreated, leads to pedal edema, ascites, pleural effusion, hepatosplenomegaly, myocardial infarction, cardiogenic shock, arrhythmias, dyselectrolemia, mesenteric insufficiency, respiratory arrest, and ultimately death. So differentials when patient shows some symptoms of sudden onset, tachypnea, dyspnea, desaturation, rales, or there is pink frothy sputum, could be either cardiogenic pulmonary edema if there are arrhythmias present, or new arrhythmias, new ST changes, or left-sided heart failure. Then this points towards the cardiogenic cause of pulmonary edema, and further could be proven by ECG or echo. If all these arrhythmias are not present, then there could be excessive of fluid or overload, or excessive fluid administration, which could also lead to volume overload, and then the differential could be the fluid maldistribution, which can be confirmed by again electrolytes. If there is a if this is not the cause, then there could be a traumatic brain injury, or hemorrhagic brain injury, or any space occupying lesion, which could make the diagnosis as the differential as the neurogenic cause, and this can also be due to acute hypertension as well, leading to brain bleed. If this is not there, if any rash is present, hypotension, bronchospasm, or any exposure to allergen, in our case there is exposure to many of our drugs, so this can lead to anaphylaxis as the cause of pulmonary edema, and this can be confirmed by tryptase levels. If all these are ruled out, then if there is any evidence of acute airway obstruction, then this could lead to basically the negative pressure pulmonary edema. And if this is not there, then the final diagnosis could be ARDS or acute lung injury. Treatment for this cause for pulmonary edema includes early diagnosis, because this decreases the mortality, re-establishment of the airway, adequate oxygenation, a positive pressure ventilation, diuretics, and PEEP to promote the alveolar ventilation. First, the general management is the initial management of ABCs of resuscitation, supplemental oxygen, 100% of oxygen, securing an airway, we can provide mechanical ventilation, which could be non-invasive through BiPAP, CPAP, or face mask with a reservoir bag providing 8 to 10 liters of oxygen per minute, or invasive could be ET tube intubation. The ventilation should be such that it provides 6 to 8 ml per kg of tidal volume, PEEP of 6 to 8 centimeters of water, respiratory rate of 10 to 12 per minute, with FiO2 of 1, and gradually reducing the FiO2 to 0.7 after first hour of ventilation, and patient should be ventilated at least 12 hours until the symptoms resolves. The medical management includes basically three goals: to reduce the preload, to reduce the afterload, and in case of hypotension, then to provide inotropic support. Preload reduction can be with NTG. The afterload reduction with ACE inhibitors and ARBs if there is refractory hypertension. Adequate pain relief in terms of around the clock analgesics or epidurals. If laryngospasm is suspected, then breaking the spasm using succinylcholine. Avoiding laryngeal irritation by using the topical anesthetics, and deepening the plane of anesthesia. So, and diuretics should be used usually furosemide at a dose of 40 mg per kg, 40 mg IV, that is at a dose of 0.5 to 1 mg per kg. So that's this much.
Head and elevation is another important
Yes, sir.
position.
Yes, sir. Head and elevation. Yes, sir.
Right. So again, for want of time, we just go to the presentation.